Nope.
Hey, Dr. Dave.
Hello, how are you?
Good, sir. Yourself?
Good. All right, is that actually going to show up or not?
So it's just kind of white, right? Is it on your screen or is your screen white?
It is. No, my screen has words on it. Oh.
That's weird. This worked last time we did this too.
Yeah, if I go there, it works.
Yes.
So if I shrink that,
It's white again.
it disappears.
It's so weird. It's the PowerPoint presentation, right?
Yeah.
Do you want to email it to me maybe? And I can press through it if you'd like. That works for you. Or
Yeah, I can do
weird.
it.
I don't know why it's been doing this recently.
For some reason, it only wants to show what I've got here. I wonder if...
Analog. Always better, Marcos.
Analog. Oh, we're having this again. Holidays, Dr. Wood. We can't talk about this.
Okay, it's loading it to Google Drive.
Okay.
Then you'll have it. The other thing I can do is once it goes to Google Drive, it seems to be showing whatever I put on my from my internet side, but not on my desktop. So I might be able to just open it through my email and get it that way. But you can shuffle through it as well.
Okay.
It's kind of huge. It's taking a little while.
Yeah. No worries. It's never given trouble with Google Meetings, and then the last two times, just the screen sharing it, and this type of thing has been a little difficult for some reason. All right, it's working now.
Mm-hmm.
So we can see your screen.
Okay. All right, I just solved my problem. There we go.
Awesome. Looking good.
I don't I don't think I ever taught a single class lecture that didn't turn into this process.
Yeah, right.
Because even if I figured it out by the next week, something was different. And some teacher had left something on a different input or a different something else. And 10 minutes into class, I'm like, there, now it works. Or in some cases, it just never worked.
Oh, gotta love it. Gotta love it. Good. Whenever you want to start, I think we should be good to go. I think stragglers will come
Okay.
on as. Thank you.
Okay, so I'm going to talk mostly about cranial nerves. This is actually, this PowerPoint presentation, I probably won't do all of it. It's actually designed, I was building it as a lecture for the advanced Gonste class we're building. So that's why it was called week 2 lecture. It's actually supposed to be a lecture for a whole class. And so when it's finally completed, it'll have more TMJ stuff, but I don't have a lot of TMJ stuff on here, but I can talk about it a little bit at the end. The main thing I want to talk about is cranial nerves, and I don't know if that'll take 30 minutes or 30 hours. It won't take 30 hours. I really don't know how long it'll take, but there's a lot of interesting stuff here that we could talk about. When I first got into looking some of this stuff up, I thought it was rather interesting that there was so much information to find that it really doesn't show up in any of our books. So I guess I should start with that preface that you won't find anything in the chapters about cranial nerves, really, not a whole lot. You don't find a whole lot, even in Plogger's book, which would probably be a more appropriate place for it, but you don't see a lot in there. And so it seems a lot of the stuff we now know about cranial nerves, a lot of what we know is only really probably a couple years old. So that's a big part of why it is the way that it is that we're still learning this stuff. And so a lot of what I'm giving you, I will freely admit it's probably not complete, and some of it's potentially even wrong as we continue to learn more. But I think there's some interesting concepts here that apply to chiropractic, partly because one of the things I'm going to show you with cranial nerves is a potential means of subluxation whereby subluxation does not cause direct insult or assault or trauma to the nerve, but it indirectly does. And so it still has subluxation as its root, but not in the same direct way that we would think of with spinal nerves. So we'll see. We'll see where we go with this. If this works. Okay. So I always wondered about the cranial nerve. So there's a lot of different ways we can pair the cranial nerves together. And so the one that makes the most sense is that you'll notice the way that the reason certain ones have certain numbers is because they're basically numbered based on their point of origin from, I guess it'd be most cephalic, but highest up, most superior in the brain, working its way down. So pairs 1 and 2, they originate above the brainstem. 3 and 4 originate in the midbrain. 5, 6, 7, and 8 are in the pons or the trochlear bridge, and pairs 9, 10, 11, and 12 originate in the spinal cord itself. So I always wondered did they arbitrarily assign these numbers, or how did they get their numbers? Well, that's how, is they just started counting from the top to the bottom, and there you go. Really complicated. Then you can also group them based on function. So 1, 2, and 8 are pretty much all sensory. And you can think about that. Olfactory is sensory. There's no olfactory motor. That'd be kind of funny though. Optic nerve, there are like 3. 3 is actually has a motor. But 2, the optic nerve itself is just sensory. Same with 8. Movement of the eyes, that would be 3, 4, and 6. So they are more motor because they're motor movement of the eyes, while the sensitive part is 2. Activation of the neck and tongue muscles is 11 and 12. And we're going to talk about them some today because that's an area when we get more towards the mouth. I could probably improvise for like 3 hours just on that alone because there's so much information about that area and things that I've found in that area. Mixed function, we've got 5, 7, 9, and 10. So we're going to talk about those as well because of their mixed function. That makes them a little funky compared to others. And then you've got your traditionally parasympathetic fibers, 3, 7, 9, and 10. We'll dig into this a little bit more, but we now know that that's not correct regarding 10. 10 is actually both. It is parasympathetic and sympathetic. So I'll talk more about that when we get to 10. Okay, so when we're talking about optic nerves, I mean, we're talking about cranial nerves, like the optic nerve. Obviously, you're not going to suspect it could potentially be an L5. Like that would make no sense. So not only L5, but there's a number of things we can rule out. The entire pelvis, the sacrum, L5, L4, L3, just keep going up and up and up. In fact, even in the cervicals, not really an effect. What happens is the cranial nerves come out, and I've got some pictures in here you'll see, but they have to fit in this really dense, tight space until they can get down to about C2. And once they get to C2, then they have room to open up and move away. And once they move away, the spine's not really going to affect them. So you're not really running the risk of having a, I don't even know what you would call it. Like it was synapses, we call them pre and post synaptic. I don't even know what you call it. It would be pre or post that exiting spot of the it's actually, well, I guess it's technically the carotid sheath. So once that exits the carotid sheath, there's no longer any way that the spine's going to affect it. So the way we can separate these out is I made my own separation based on how subluxation would affect them. So 1, 2, 3, and 4, because they originate so high in the brain, nerve pressure is created by direct tension on the nerve. So that's not totally, okay, so we'll go through these, but as we go a little further in, I will explain to you a way in which cranial nerve 2 could have a problem that would affect the eyes, but it's not actually linked to subluxation. The thing is, with 1, 2, 3, and 4, we'll just say those 4 for absolute, they don't leave the head. So no matter where I move my head or position my head, the distance between their origination in the brain and their end target, it's never changing distance. And there's nothing really to occlude them because like I said, I have slides here. I'll show you some pictures of how they exit the foramen. Or like in the case of the olfactory nerve, it goes through the cribriform plate. So is the cribriform plate ever going to subluxate? Not really. So it's never going to cause any kind of direct pressure or anything like that. So that whole concept of subluxation doesn't really apply here. And that's really my only point. I just said it the long-winded way. When you get to 6, 7, 8, 9, 10, 11, and 12, now nerve pressure can be created by mechanical pressure to the nerve. I'll tell you, I'll give you an explanation for mechanically how the occiput could do it. Atlas can do it mechanically, and C2 can also do it in a very weird way. So we're going to talk about that one too, because that's one that we don't talk about a lot in Gonstead world. I talked about it at the Meeting of the Minds 2 Meeting of the Minds ago. So whatever year that was, I think it was 20. It was 20 when we did it at Mount Horeb because we couldn't go anywhere else. Cranial nerve 5. Here's one that's a little bit different because nerve pressure can be created by the atlas, it can be created by the TMJ, or it could also be abnormal dentition. So I'm not going to go a whole lot into abnormal dentition. Basically, that means bite problems, and there's a number of them that you could have. Okay, so let's start with cranial nerve 5. We're going to rule out 1, 2, 3, and 4, and we're going to say that chiropractic has little effect on 1, 2, 3, and 4. However, I'll explain to you how what can happen to 1, 2, 3, and 4 is those nerves can be affected by viruses. So this was kind of what I talked about at the Mount Horeb Meeting of the Minds, is that viruses, when they enter the body, there are multiple studies that show that viruses enter the body usually through either the respiratory system or the digestive system. They immediately try to make their way to the brain. And the question was, how do they get there? And the most efficient means for them to get there is through the vagus nerve. So that's typically what they take. There were experimental studies where they took animals that were exposed to a virus. They gave them a unilateral vagectomy. So they severed it on one side. They found that the side of the brain that still had the vagus nerve intact, the virus made it to that side of the brain 3 days faster than it made it on the other side. So is the vagus the only means of getting there? No, it can still get there. It will get there. But does it get there as fast? No, that slows it down if the vagus is severed. So the vagus is the most direct path to the brain. So when you think about viruses, you can think about this with COVID because it's a virus. So what does it do? It gets in, it tries to get to your vagus, and it tries to get to your brain. And then once it gets to your brain, it starts affecting other systems and how they work. one of the interesting things about COVID, very early on, I found in the research that people were already mentioning that post-COVID, there was a high amount of dysautonomia. Well, what is dysautonomia? It's dysregulation of the autonomic nervous system, mainly through the vagus. Well, why is that happening? Because the virus just used the vagus to get to the brain. It disrupted the vagus on the way, and the vagus is not able to self-repair that way. So you end up with a lot of this post-COVID stuff. So right now, I don't think it really matters which variant or if you had the original COVID or whatever. All of them are going to do this one particular thing. So if you've had COVID at all, you probably have some degree of dysautonomia just because it used your vagus nerve to try to get to your brain as quickly and as effectively as it possibly could. So that's where we have viruses getting up there. Now viruses can then affect nerves. So could that be a cause of problems with 1, 2, 3, and 4? Yes, it could be. Two in particular, however, has an issue where Ross Hauser describes this as he has what he calls the brain toilet. And basically what the brain toilet is the cerebral spinal fluid in your brain. It has to drain into the jugular vein to be flushed out, because anytime you have direct brain trauma or you hit your head or anything like that, it releases chemicals into the cerebral spinal fluid. Those chemicals are toxic to the brain. So the brain flushes the brain toilet and it flushes those chemicals out. You can have occlusion at the atlas, basically at the foramen magnum, atlas, that whole area, that blocks the brain toilet so it's not able to drain. Now the chemicals in the cerebral spinal fluid, they build up and they stay there. Plus the cerebral spinal fluid itself can't drain. So that starts to create pressure. That pressure will show up by causing swelling of the optic nerve. And so you can detect the presence of that kind of brain swelling by looking at the eyes, which is kind of funky. So that's something he does. If you want to look him up, it's Ross Hauser. You can go on YouTube and look up Ross Hauser. He does a lot of stuff with people with Ehlers-Danlos and stuff like that. I find him interesting. So I started looking at his stuff. But when it came to the brain toilet, I was like, this is super relevant because it's my theory only. I think that what's happening when people get CTE is that those chemicals are building up in the brain. They're not able to flush the brain toilet. So those chemicals irritate the brain and cause release of more chemicals, which irritate the brain and release more chemicals. And you get in this cycle, and the cycle keeps going and going and going until it eventually affects the brain to the extent that they lose their mind and they do crazy stuff, whatever that may be. They become suicidal, homicidal, whatever, because their brain is so assaulted by its own toxins that it released. So that's just my theory. But you would see then, if that is true, the best solution for people with CTE would be to get adjusted. So I think it would be interesting to do a study of people with CTE and see if adjustments help them in the long run, and just especially applying it a certain way. But anyway, so that's how those go. So let's jump down to cranial nerve 5. Cranial nerve 5 has both motor and sensory functions. The motor obviously is for the muscles of mastication. The sensory is for tactile, proprioception, and pain. There's a particular branch that we're going to talk about in a little bit. So the trigeminal breaks off into 3 branches. They typically call them V1, V2, and V3. They exit through different foramen in the skull, and V3 is ultimately the one that goes. So the V3 of the trigeminal becomes the mandibular nerve, which then becomes the lingual nerve, or it can become part of it becomes the lingual nerve. The lingual nerve runs through the tongue from the back to the front. And so when we get to talking in a second about, when we talk about frenectomies, tongue tie, lip tie, that kind of stuff, when we talk about tongue tie, that portion of the tongue is innervated by the trigeminal nerve, not by the glossopharyngeal, not by the hypoglossal, so glossopharyngeal does go down there, but glossopharyngeal does the posterior 2/3. So when you're doing a frenectomy and a tongue tie release, you're really only affecting the trigeminal nerve. So we'll talk about that more here in a second, but I just want to kind of set that up. So when we have cranial nerve 5 dysfunction, it typically will come from either the TMJ or it can come from the lower third molars. So I was always taught, and anybody on here who's my age and older will know that we were always taught, when you see on your full spines, when you look at the patient's face and you see a tooth where you're not looking at the tooth from the side, but you're looking at the tooth from the top. When you look A to P, you're seeing the top of the tooth because it's sitting like this instead of sitting like this, but it's turned this way. When you see those, we recommend that you send them to a dentist. That's what I was always taught. So I told my wife that that's what we were always taught, and I asked her, were we correct? And she said, yeah, because that part of the mandible gets really thin. And so when they turn this way and the roots project backwards, third molars tend to have really big roots. And the roots could be longer than even the mandible itself. So as they project that way, they basically encroach right into the space where the trigeminal runs. And so those roots can get tangled up with that very, very easily. And so in that way, you could have a dental subluxation, if we wanted to call it that, which means that all the adjusting in the world isn't going to make much difference in that because you got a tooth buried in on that nerve. So that is definitely one to consider. And we always do try to consider that one because you don't want to be just whacking away on somebody trying to make subluxations out of nothing just because you think it should be there when it could be as simple as a tooth doing that. So that's one. When there is problem with the trigeminal, it typically will present as jaw pain and headaches. There is the fear always of trigeminal neuralgia or tic douloureux. I've only ever had one patient with tic douloureux. I don't know, maybe Dr. Wood's seen more than me of that, but I've only ever seen one. And it was bad. I will tell you it was bad. But I also will tell you it was an atlas that was doing it. I haven't seen a lot of that, but you can always get that. Okay, 7. The motor is for muscles of facial expression and the lacrimal and salivary glands. These are ones, I think when I'm going to show you a mechanism, I'm going to go through all these and then I'll show you the mechanism by which I think they get affected. It's a pretty subtle mechanism, and because of that, these are symptoms that they seem minor. Like if somebody came in and told you that their eyes were watering too much or that their eyes were dry, you kind of go, oh, okay. But like, you're not going to die. So is that a big deal? Maybe that's just you. And so you don't really know, is that just them or is that something important? And so a simple thing like that, or they have dry mouth. You just kind of go, well, I think a lot of people do. So maybe you underestimate that. But it could actually be a problem with cranial nerve 7 that's doing that. The sensory portion of cranial nerve 7 actually collects the taste data. So that's what when your brain is perceiving taste, it's using sensory of 7 to do that. Obviously, cranial nerve 7 is associated with Bell's palsy. And I've seen a lot more of those than I have the tic douloureux. I've actually, for some reason, I've seen a lot of Bell's palsy patients. I think what happened was I got one. You know, when you fix something, then everybody who has that started coming to you because they all know each other. So I've seen a good number of Bell's palsy. And again, you don't get confused. You know where it is. And so I do want to tell you that as I'm going through this, we could make this super complicated, but in most cases it's not. And so when I was younger, and I still do it sometimes now, I always remind myself to use the KISS method. So I'll be sitting behind the patient and I'll tell myself, just keep it simple, stupid. Like, don't overcomplicate this, because in the end, it's all just to find the subluxation. So when we make it super complicated, it's only to give us clues to figure out the subluxation. But still, once you know what the subluxation is, you know what the subluxation is. Now just go do your job. It doesn't get it. You don't. That's just the way it is. So, so cranial nerve 7 could be impingement at the atlas. It can also get trapped there. But also, what I'm going to show you, I think the occiput could also do it. Now, that doesn't mean the occiput is a major cause. I just know that any rule we try to make, there's going to be exceptions. And so if we try to say it's always atlas on 7, well, there's probably going to be some people who it's not atlas. And if it's not, it's most likely going to be occiput. Cranial nerve 9, okay. It is the motor and sensory to the posterior 2/3 of the tongue and the pharynx. So one of the things, oh no, sorry, that's a different nerve. So it also provides sensory for the taste buds. So when we do taste, it's cranial nerve 7 and cranial nerve 9. It affects the parotid. I don't know if you've ever seen this, but I've encountered a few people who had problems with their parotid gland and they did not have the mumps, but they still had problems with their parotid gland. And so typically it's an upper cervical, often atlas, but again, that goes back to 9. Um, will you present there's parotid swelling because of the Sorry, I got kicked off.
You're all good. I think you froze, and we stopped hearing right when you were talking about the parotid at 9, at the end of the parotid. Go ahead.
Okay.
Yeah. Sorry.
Okay. Yeah, so honestly, I can't say that I've seen a whole lot of patients that I thought, oh, that's definitely a cranial nerve 9 problem. But I guess one of the things you can think about is that if you can see how many of these are linked to the atlas. If you adjust a patient's atlas, obviously that's a very profound adjustment. Your potential for affecting things is tremendous. Same with the occiput. So I'm going to talk about the occiput more here in a second. But we'll go to 10. 10 is mixed sympathetic and parasympathetic. So here's why that's super unique is I'm sure you were taught in school, I was taught in school, that cranial nerve 10 is parasympathetic. But it actually has this sympathetic side on the ventral side is sympathetic. So what it has the ability to do is it can apply the gas and the brake. It's like having a gas pedal and a brake pedal. And so one of the things that it can do, I don't know if anybody watches NASCAR, but if you do, it's my best analogy. There are 2 races, Daytona and Talladega, where they use restrictor plates. And so because the restrictor plate starves the engine for oxygen, it takes like a whole lap to wind up to speed. And so when you race a restrictor plate race, which I love doing on the video game because it's so much fun to race that way, but you have to know the technique. And the technique is once the flag goes green, you go pedal to the metal on the gas, and no matter what, you never let off. Never, ever, ever, ever. If you need to brake, you brake, but you keep the gas on. And the reason why that works is it keeps the RPMs high and it keeps you revved up. So you can control your speed with your brake and you just keep your pedal on. Well, the cranial nerve 10 will do the exact same thing. There's evidence of it doing the same thing. I was reading about it in the literature, and immediately that was the analogy I came up with. So I was like, I can understand that. You keep the gas down and you pump the brakes, and that's how you control your speed. Actually, you drag the brakes is what you really do. So cranial nerve 10 will do that. It'll go full sympathetic, and then it'll kind of pump the parasympathetics in order to control the speed of what's happening. And so the only variability is on the parasympathetic side, not the sympathetic side, and the sympathetic side is full on. So what it does is it gives it that variability. It could also do the opposite. It could put the brakes full on, and then it could use the gas to go on and off. It could also have them both on, which would be kind of weird, but it can do that. And you can think about that. If you're in your car and you put your foot on the gas and your foot all the way on the brake, you're going to rev up really high, but you're not going to go anywhere. So you would have the illusion you were going nowhere, but you'd be all amped up. This can do that. So you can think of somebody having like anxiety or a panic attack. That could very well be both systems pedal to the metal. And now their brake is fully on, but they're all ramped up on the inside and their RPMs are high, but because they're both stuck on. So you can have that side of it too. So that makes cranial nerve 10 a very strange nerve. The fact that Stephen Porges wrote the polyvagal theory, and that book, I swear, is like this thick. And the whole book is done nothing but the vagus nerve. Like, I don't know of too many nerves you could write a book that thick about it. So it is very interesting how that all works, and the fact that because of that, it's also tied into our emotions. So classically, we're taught that chiropractic subluxations are caused by trauma, toxins, and thought. And so everybody understands that thought side. But do we have, one of the questions that came up at that meeting of the minds a couple of years ago was somebody said, do we have any evidence that it's actually true? And the answer was, well, we do now because of Stephen Porges. And the polyvagal theory is what lets us know that it is true. And so that's when I started diving into other things to see if I could tie them together. So, for example, I've given this example a bunch of times on the 1505 Club, but the idea of people with PTSD have more sleep apnea. Well, why is that? There's an emotional trauma that affects the vagus nerve. Vagus nerve affects the palotoglossal muscle. When it gets paralyzed, it closes the airway, and now you're going to have more sleep apnea. So the thing was, based on polyvagal theory, I theorized that that would work that way. And then I went to the research to look it up and found overwhelmingly that people with PTSD have dramatically high levels of sleep apnea, like twice what you'd expect in the normal population. So there definitely is this connector that people who experience traumas and things like that, they do show up physically. And one of the physical signs of that could be sleep apnea, just for one. The other thing about cranial nerve 10, and again, I got this from Ross Hauser because he was saying, we don't teach it this way. In fact, there was a whole, we were having a email conversation with, I don't know, like 5 of us. And Dave Geary said, it doesn't really work that way, except that clinically it kind of does. So here's how it works. Typically, clinically, you find that if the left vagus, oh, the video looks like my right side, but I'm pointing my left. The left vagus affects the digestion, and the right vagus affects the heart. So if you think about the wings of the atlas and how they spin, the one that goes, the side that's anterior, whether you have an ASLP or you have an ASRA, the side that's gone anterior of the wing is going to affect that vagus. If it happens to be on the right side, ask about heart symptoms. If it happens to be on the left side, ask about their gut, because most of the time that's the way that it works. In fact, I had a patient with Ehlers-Danlos syndrome. She didn't know she had Ehlers-Danlos syndrome. She got in a car accident, had a really bad whiplash. The effects of the whiplash were so severe that that's how she found out down the road that she had Ehlers-Danlos. She then found out that her son has Ehlers-Danlos, and perhaps more importantly, she found out that her dad, who committed suicide, had Ehlers-Danlos, and he probably committed suicide because of basically having a brain toilet that couldn't drain, essentially. And so it made him suicidal. He showed all the signs of CTE, except without any CTE. So it's very interesting. Vagus nerve. The other thing about vagus nerve is responsible for all sickness behavior. So that's one of the reasons why people who get bad whiplashes might have gut issues. But if you've ever done something where you were looking down for a really long time, and then you look up and you kind of go, ooh, kind of queasy, it's probably vagus doing that. Because when you go into full sickness behavior, which means vomiting, diarrhea, fever, all that, those typical things, vagus is what triggers that. So I don't know if it's because of that viruses try to get their way to the vagus as a way of getting to the brain and shutting that system down, or if it's because viruses are so attuned to the vagus that the vagus is the perfect place to register that and be like, oh, virus just used me. We better trigger a sickness response. We got a virus. So it may be an early detection system. I don't know which way it goes, chicken or the egg, but either way, it works out. So the vagus nerve also affects changes in gut permeability. That's the reason why the vagus, if it chooses to, decides you're sick, it can initiate changes in the gut permeability that lead to diarrhea. That's one of its ways of quickly flushing it out. So that message doesn't even have to go all the way to your brain. The vagus is aware of what's happening and it changes gut permeability. So when you've got people with leaky gut syndrome and things like that, a lot of them have dysautonomia. So they have a problem with their vagus nerve that's causing their leaky gut, which is why when you look at studies, you can flood people with probiotics, but if you don't fix the leaky gut neurologically, those probiotics are just flushing through. They don't make a difference. You have to first shut that down by fixing the vagus nerve. Also, there's a cool product. So this is a long story. I'll shorten it. Let me think. I had a bunch of problems with my liver, so I had to have a couple surgeries. And after the last surgery, I started having lots of problems with my gut. Stupid me, I then theorized they probably stuck antibiotics in my IV and didn't tell me, and destroyed all my gut bacteria. So I was super sick. So I thought, all right, well, no problem. I'll just do probiotics. I'll do this thing. I'll fix it. So I started doing that. Not fixing. And I was like, man, I think it's getting worse. It got so bad that I would get sick drinking water. And I was like, now what do you do? So fortunately, my wife found this product. So she was like, here, take this. I'm like, all right, whatever. So I take this stuff and it totally fixed it. It's called, so it actually, it's a product that comes from Dr. Zach Bush, if you know who that is. And the product is called tetrahydrite. So basically, one of those two names is an actual chemical compound, and the other is not. It's a trademark name intended to sound like a chemical compound. I can't remember which is which. I think terahydrite is what it's actually called, and I think tetrahydrite is what he called it, or something like that. Anyway, this stuff is pretty amazing. It has the ability to tighten the loose junctions in the gut. And so it seems like the vagus nerve, once those junctions are open, the vagus can have a hard time fixing the problem it's created. But that if you go backwards and you use this product to shut those loose junctions, that has a backflow effect to the vagus that helps to correct the dysautonomia. So you basically fix the nerve by fixing the gut, since you can't fix the nerve to fix the gut. So that's an interesting idea with this all as well. So the vagus nerve, this is why we could talk about the vagus nerve for forever. It does so many things, and it's so important. It's easy to screw up, and it's really hard to fix. And so if it does happen to have pressure up at the atlas, it's an atlas adjustment's an easy solution, and then that frees it all up. So you need to start that process. But for me, mine was all messed up, and I've never had an atlas problem. I never had even when I just finished playing football in college, I still did not have an atlas problem. Like, I don't know how I got away without atlas problems, but I had enough problems in my low back, but I had no atlas problems. So I was like, it's not my atlas. So how do you fix this if it's not the atlas? Well, that's when I theorized they must have poisoned me with antibiotics. So I had to go the other direction. I had to fix that problem to run reverse, and that actually did work. Another thing I briefly mentioned is that the cranial nerve 10 innervates actually goes beyond that. You can take the muscles of the mouth and you can divide them into different things. So there are some muscles that form the upper arch. There's muscles that form the airway. There's muscles that control tongue movement. So I started looking through these different categories of mouth muscles. And in every single group, there was just one muscle in each group controlled by vagus. And so I said, okay, so what do all these muscles, these one muscles, do they have a common function? And they do. Every single one of them has the effect that when it tightens and it contracts, and this seems weird, it seems paradoxical, when it contracts, it opens the airway, which means that if those muscles collectively are paralyzed, it closes the airway. And so when it comes to sleep apnea, there's still quite a bit of debate as to what's really causing it. Is it the tongue falling back, which one of the muscles actually works to hold the tongue up? So yeah, that's part of it. So it seems like true sleep apnea is not one thing happening. It's a collection of things happening because all these different muscles have the vagus as a common denominator. And when the vagus gets in trouble, these individual muscles shut down, they become paralyzed, and the net result is the tongue falls back and the airway gets smaller. So, so that it seems, yeah, this is part of the part that I'm still developing. I'm still figuring out what all of this means, because I think in that way, sleep apnea could be a great indicator of dysautonomia. It might be the prime indicator of dysautonomia. So if you take everybody, once you discover somebody has sleep apnea symptoms, then you can say, okay, we've got cranial nerve issues and dysautonomia. We need to figure that out. And as I'm trying to point out, it could be an adjustment, but it also could be something else that needs to be fixed in order to reset the nerves. So it definitely gets and stays complicated. Also, cranial nerve 10 provides sensory and motor fibers to almost all the visceral organs. And nobody ever goes, oh, my liver, or oh, my spleen. So because we don't know about these organs, they could be totally dysfunctional and nobody's going to directly complain about them. And so once you know the vagus is involved, it makes the most sense to assume that it's affecting all their internal organs, at least a little bit. Probably not deadly, obviously, or they wouldn't be there, they'd be dead, but enough that it's going to create some systemic dysfunction. And so a lot of times you see people who you can't really put your finger on it. You just go, this person is like really sick, just sick. In fact, I guess there's an old joke about, I can't remember who it was, but it was basically on, I think it was Dr. Gonstead on one of the old travel cards, that they had like symptoms, and he just wrote sick. Because there's times you're just like, they're sick. I don't know what to tell you, they're sick. So that, I think, links to cranial nerves. Cranial nerve 11, which is also known as the spinal nerve. That would be the accessory. It activates the trapezium and sternocleidomastoid muscles. Here's what I think is interesting. Is its action, when it works together, it causes head extension and lateral flexion. Well, I was thinking, if you were to do a supine cervical, what position do they usually put the head in? Extension and lateral flexion. And I don't really know what that means, but I think there's something relevant there. I'm not sure what it means, but it's kind of like that's, I don't know. I think maybe it just because you can go with the body's natural movement, and that makes you feel like the body's letting you do something that still might not be a great idea. But anyway, the big thing about this, and I think the last time I talked with you, I don't remember exactly what we covered, but we talked about torticollis. So cranial nerve 11 is the cause of spasmodic torticollis. So the important thing is to know the difference between spasmodic torticollis and non-spasmodic torticollis. So I can tell you briefly again. Let me sit straight so you can see. When a person has torticollis, they're like this, you go to the side they're going to, and you try to pull them up to straight. If you pull them up to straight and they hurt on the side they're bending to, that's spasmodic torticollis. If you try to pull them up and they hurt on the other side, that's non-spasmodic. Spasmodic torticollis is an atlas problem affecting cranial nerve 11. Non-spasmodic torticollis is typically an upper thoracic, T1, T2, maybe C7, but really T1, T2, T3, most likely. I find a lot of them at T1 and T2. So, hold on a second. Sorry, I'm about one of my many devices is almost out of power. Okay. Okay, so spasmodic is cranial nerve 11, non-spasmodic upper thoracics. Um, so last time we went to a whole detailed thing, and I talked about how when I teach that at Life, I use 2 YouTube videos. And basically what I show them is one video where it's a non-spasmodic, and it happens to be a Dr. Ian video. He recognizes it as such. He adjusts the T1 on the kid, and the kid's better in a matter of minutes. The next one is somebody who clearly has a non-spasmodic, but the chiropractor assumes that it's spasmodic, as though they're all atlas. And even though the patient is constantly telling him, it's right here, like pointing at it, he still insists on adjusting his atlas. And 4 days later, the guy's still not better. So, in fact, the students always find it kind of profound, because that was when one of them pointed out, they're like, the guy's basically showing him where it is and begging him to adjust it, and he still won't do it. So you don't want to get in that trap. So it's important, I think, to know the difference between the two, because they present looking the same, but by one little thing of just trying to straighten it out, you can find out if it's spasmodic or non-spasmodic, and they'll lead you in 2 different directions, and one will fix it and one won't. Okay, and then cranial nerve 12. This one, it does activate the tongue and the swallowing muscles. So this one I think is interesting, because if you look at the third thing down, the proper functioning is an indication of overall health. So what it basically means is with good overall health, there will be good coordination between tug movement and swallowing, and the two should go together. As you swallow, and the tongue has to shift with that, so they should go together. Again, most likely impingement is the atlas. Okay, so here's what I want to show you. Hopefully you can see that pretty well. So what you can see on here is, here's all the foramen where all the nerves go through. But on the right side, you can see each nerve assigned to its appropriate spot. You'll find that the lower numbered ones, the ones that originate higher in the brain, they're the ones that exit more to the anterior. As you move posterior, you get more of the later ones coming out. So this is interesting to me, because here's my idea. Do I have a, no, oh, you know? No, but won't let me do it. Okay, never mind. I was trying to use my cursor. Okay, so if you look on here, if you look at where the foramen magnum is.
Dr. Fowler, we can
the
see your
occipital
cursor.
condyles are just lateral of that, right? So when the head moves, it's not pivoting on the center of the head. If you had a skull and your pivot point was the middle, then basically for every millimeter you dropped your chin, you would raise the back 1 millimeter, and vice versa. So it'd be 1-to-1 ratio. But because the pivot point is on the back 1/3, when you move your head, basically for every millimeter that your EOP comes up, your forehead is actually going to drop about 2. So it's more of a 2-to-1 ratio. So what's happening here is you move your head. If you think about all the cranial nerves that do leave the head, that go past the foramen magnum and either go to the muscles in the neck, or in the case of the vagus, go all the way down, their end spot is not moving when you move your head. So I can nod up and down, and they're not going anywhere. The foramen magnum, because that means that when the head pivots like that, there's very little change happening there. However, this is my idea, is that if the head is in a PS occiput or an AS occiput, that's going to put mechanical traction on that nerve, which is non-elastic. And nerves that get tractioned get irritated, swell, react that way. So it seems to me that this is how the occiput subluxation, not in a direct way, but an indirect way, if you've got a PS, it would primarily be the PS occiput. The AS occiput in most cases is going to shorten the distance and actually put slack. So we don't see a lot of this with the AS. So with the AS, what you get is more of what we describe as a cord pressure, where the occiput shifts forward and the posterior part of the foramen magnum now encroaches on the posterior part of the brain stem, or the cord. With a PS occiput, you do get the front side of the foramen magnum can do the exact same thing, but you add in this element of potentially tractioning cranial nerve 7, cranial nerve, what else is back there? 9, 10, 11, 12, all exit really close to there. 7 and 8 as well. And potentially parts of 5, especially that V3 part that goes into that becomes the mandibular nerve. So I think that's why the occiput has to be looked at. It's not because the occipital condyles are creating capsular swelling that's putting pressure on cranial nerves. Now, it will put pressure on the brainstem, it'll put pressure on spinal nerves. It does all of that the same as the normal mechanism. But the cranial nerves are a little bit different in how they come out. I believe, I didn't add it on here. I meant to. Oh, well, I haven't added it yet. I'm still building this one. There's a slide that I wanted to build, or I wanted to show you. There's a picture where it shows how cranial nerve 10, as it exits, it runs through the carotid sheath with the carotid artery and the jugular vein. And they all sit really they run right by the anterior portion of C1. So they sit right up against C1. That's why if that wing comes anterior, it can very easily impinge on that. And that impingement isn't just going to cause problems with cranial nerve 10, but it actually could potentially simulate carotid or jugular stenosis as well. So, so Atlas can work with any of those. And if it actually did that, it would change blood flow as well. What was I thinking of next? Oh, I know one of the things I was thinking of. Because we all see the videos of the people doing Y strap, ring dinger. And what's the other one? Oh, even just the side. You see the side ones where they put the head on the side and they do the occipital lift from the side? Well, here's how you should think about this. And I've now reached the point where I got that question enough times at life that I've made it a part of my class, that I go through this with every class because I want them to understand it and not be ignorant of this. When you think about the occiput, it sits on the lateral mass. The most correct position for the occiput to be sitting is in the most inferior position. Because that's why our listings are PS and AS. Anything that involves S that's superior to that lowest position is a misalignment by definition. The correct position is the lowest point. And if you have a PS, you're pushing it to the lowest point. If you have an AS, you're pushing it to the lowest point. So if the lowest point is the correct position and anything superior is the wrong position, why in the world would you want to traction up on an occiput? It makes no sense. The other problem you run into is that while the joint may allow for that distraction, there are many structures in there that are not elastic, that are not going to accept that as well. One of them being the brain stem. It's not super elastic. So when you give that quick tug, like I shouldn't watch these videos, but I've seen it happen, and the people are like, "Oh, that was amazing. My hands and feet are all tingly." I'm like, "Yeah, that's called central nervous system trauma. Like you just jacked up your whole central nervous system because you traction in a non-elastic structure. It's going to let you know that was a dumb idea. Don't do that." And then they go, "I want more of that." So that is the best explanation, is that the lowest possible position is the right position. And so even when adjusting an occiput, you always make sure when you're adjusting it, your elbow is higher than your wrist. Then you're thrusting down. If your elbow's below your wrist, you can't possibly set the occiput correctly because you're only going to drive it up. So you have to always have an S to I line of drive with your forearm. So we want to get it back into that cup. And my theory then would be, if that most inferior position is the most correct position, anything superior to that is now, by definition, tractioning any of those cranial nerves that leave the head. Again, if I go PS, my nose comes with me. So my olfactory cranial nerve 1 is doing just fine. Cranial nerve 2 is just fine because the distance between the two is never changing. But for the stuff that comes even into the neck, as I do this, the distance is changing from point A to point B. And so I think when you go PS, particularly when you go PS, your risk of tractioning one of those cranial nerves and irritating it goes way up. So that would be the indirect mechanism of subluxation for cranial nerves that perhaps affects them a little differently than the regular swelling mechanism that we get with the joint capsules. Another thing that I think is really important is, sorry, I have a loud Doberman. She's hold on. I'll stick her outside. That'll solve it. The other thing is, so occiput gets in trouble with misalignment and hypomobility, and atlas gets in trouble with misalignment and hypomobility. But another mechanism that's a little bit unusual is that C2 can cause trouble with cranial nerves and mainly cranial nerve 10, and it can do it with hypermobility, which is usually something that we ignore and don't pay much attention to, because we say, oh, hypermobility is compensation, so we don't worry about the compensation, we worry about the subluxation. And that's true. If you have hypermobility at C2, what do you do about it? Do you adjust C2? No. But why is it hypermobile? C7, T1, T2, whatever it may be. And the solution is to adjust that subluxation, and then you'll correct the hypermobility. But what we don't think about is linking it together, that the hypermobility is the link between the subluxation we found and the symptoms that they're getting. So let's say you've got a patient with a C7 subluxation, but they're showing signs of a cranial nerve 10 problem. And you check their cranial nerve and you check their upper cervicals and you find no atlas subluxation, no occiput subluxation. If anything, they have hypermobility of C2. And you're thinking, well, how can this be? How do they have a cranial nerve 10 problem when only subluxation I'm finding is a C7? Well, that is the answer. It's the C7 causing hypermobility at C2, which causes the dysfunction of cranial nerve 10. So you got to fix the C7 and then watch those symptoms. And if your mechanism is correct, then as the hypermobility improves, the cranial nerve symptoms will improve as well. So that is the complicated pattern to follow. We've already talked about that. I wasn't going to go into that as much. That's actually a movie, but I don't think it'll play. But if you want to watch this movie, since you're not in my class, I don't mind telling you that. I don't mind spoiling my own thing and telling you what it is. If you go to YouTube and you look up the Yoint video, Y-O-I-N-T, it's because these guys are from, I don't know, I think they're from Norway. I'm not positive, but they're somewhere Scandinavian, I think. And so they don't say joint, they say yoint. And so it's been affectionately titled the Yoint video. So if you look up the Yoint video, they have these cross-sectional movements of the TMJ where you can really see how the TMJ truly moves and how it misaligns and where it can go. And you see how you see normal motion, you see some abnormal motion. I think it's a great video for really understanding the mechanism of movement of the TMJ. The other thing about the TMJ is that there are some ligaments in there. There's some ligaments in there that are important for holding it and maintaining it. And it is possible to rupture those ligaments. I would equate it to being like an ACL tear. The difference is if you tear your ACL, they're probably going to go and repair it. With these little ligaments, they don't like to do that because there's too much. It's not as simple a procedure, and there's a lot that can go wrong. So it's hard to find anybody who will repair it. So if once you tear one of those ligaments, you're going to generally tend to have a very sloppy TMJ from then on. That's not one that you're going to adjust and fix, because you can put it back in and they're good for a little bit and then it comes back out. And so I found with those people, I can do it and we can do it over and over. They get better and it helps them to maintain, but I always make sure they understand that it's like adjusting a knee with something with a torn ACL. You can do it, but you're going to have to do it again. You're going to do it again. You're going to do it again. It'll never be totally stable. So, actually, I don't know. Let's see if it'll play. You guys probably haven't seen this, have you? So I'll show you Jeremiah. It's going to be all skippy and weird. Oh well. If I can skip it ahead a little bit. There you can see. Come on. Pause. When you see this, here's where one of the things that I describe, and this is kind of where my presentation stops so far. I haven't built it past here, but one of the things I want to describe was what I would call the EX TMJ. That's how Jeremiah explained it to me. I guess that's what Working called it. So just like you would with a pelvis, you can see that the one that projects wider, which he has labeled with the R, the one that projects wider is the EX side, and the other side is the IN side. So what you've got is jaw rotation. And so a lot of times if you're trying to set an AI TMJ, but you've got this rotation in there, you can't get it to set correctly. So what I do, what Jeremiah told me to do, and I found this works very, very well, is you set the EX side first, and then you set the AI side. And for the EX side, all you really have to do is you just get I'm behind him, so I can't put my hand on like that on my own jaw, but maybe like that. I use my thenar on the head of it here. I have them open all the way, and you have a stabilization here, and you just push lateral to medial, and you just hold it there. And as they close, like you can do it on yourself, even with just the thumb, you find the tip of it and you push it. And as you start to open and close, you can feel how that little bit of pressure totally guides it and makes it do something different. So when they're external and you put that pressure, as they close, it just goes boop and it sets it in. So I hold it with my thenar because that's a softer contact. I hold it with my thenar. As they close, do it like 2-3 times. You can usually see that part straighten out, and then once it straightens out, then I'll come back and do the AI portion, and it makes the AI way more likely to do what it should do once you do that. So that's a little tip. Yeah, actually, I did a class on that at the last extravaganza, so I covered some of those things on that. So let's see if he's got anything else on here. What I talked about in that class is initially I had a lot of trouble with TMJs. I didn't feel like they were really setting the way I wanted them to, and I didn't really feel like people were getting better the way I wanted them to. And there was 2 important discoveries I made that made a world of difference. One was Jeremiah teaching me about this EX side. Okay, it is moving. The other was another little tip I'll show you here in a second. Let's see if he's going to show. Okay. So here you can see him do it. Bring it over and back. So this is what's interesting. He does it the way that Mark Working taught it, the way that I learned at school. And we bring it over and bring it back. And that worked okay. But there was another thing that I discovered. I'll let you just kind of watch this and I'll tell you what I discovered. So I was getting a bunch of stuff from Josh Lawler that I was using for building this class that I'm building. And he sent me something, and it was a bunch of cartoons that Dr. Gonstead had drawn up. In fact, at the last extravaganza, they had them in the room where all the vendors are, and I think that they'll still be there. So if you go to the extravaganza, go in the room where the vendors are, and I think they'll be in there, and you'll see that there's these different cartoons that were drawn up. One of them is for TMJ. And what it says is it had this one little piece of it where it said that you pull posterior or you pull anterior to posterior for the first 1/3 of the jaw movement. Maybe. He gave it to me and I don't know. Actually, I don't know. I don't know if I have it. I don't know. He's got others though. He's working on others. This one was a little too artsy for him, out in the desert. Anyway, he told me it was a little too artsy for him, but it was a good first try. He's put together some other stuff, so he has some other things. But on this cartoon, it said you pull anterior to posterior for the first 1/3 on the jaw, and then it says that before you pull up, you actually push inferior before you come up. And I thought, well, that's weird. How come I've never heard of that before? So I went to the chapters and I looked, and in the upper left-hand corner on that page, it actually says in there to pull inferior. I'd never seen it before. I was like, okay. So I started doing that. I would pull anterior to posterior, and then right before I transition, I push down and then pull back up. And what it does is it suddenly made so much more sense to me, because if you're trying to just pin the disc and move it, one of the problems you get is some people get medial misalignments of their TMJ. How are you going to catch that and kick it lateral? But if you drop it down, what you're really doing is you're using suction. You're opening up this closed system, and you're using suction to pull the disc from wherever it is back to a neutral spot, and then you're letting the joint slam shut on it. So this S to I component that pulls down before it comes up, was one of the keys that made it so the AI started working a whole lot better for me. Oh, speak of the devil, there it is. That's the cartoon. So right here, it's on number 3, about halfway down. It's C. Flip the wrist so that the left hand, pisiform, slips under the left jaw, then press inferior, then superior. And I was like, inferior and then superior? I never heard of that. So, like I said, it made a big difference for me when I was adjusting people to start changing that out. So I've been doing a lot of TMJs lately and getting much better results with them, a lot of different people. So that's something to look at. So if you go to the extravaganza, this poster is actually really large. It's not tiny like this, it's really large. So go there and take a picture of it. Actually take a picture of all of them and then stay. There's like 5 or 6 of them. So there's the, yeah, that was the end of, that's the end of what I had for my slides. But yeah, that's pretty good. So that's basically the idea of the cranial nerves, is that there's a lot to understand about cranial nerves. There's a lot of symptoms that they can create that we would probably dismiss regularly. And yet I think the mechanism by which they get bothered is either by atlas pushing on them, or it's by occiput shifting and putting tension in them. And either mechanism will cause a problem with it. It's also possible that they have very low level, it has a low level effect. So the symptoms won't be super severe, although they could be. But in a lot of people, they're going to be minor. And then they're weird things like the tear ducts or the salivary glands or weird stuff like that you normally wouldn't equate for anything. So when you know to listen for those things and they happen to mention it, you kind of go, huh, I wonder if. And usually for me, that's where it starts, is I just go, I wonder if. And then I scope them and I get that reading at the upper cervical and I go, that's interesting. They told me they were having this problem and I'm finding this. Let's just keep going down that road and see where it leads. And so it's all just clues to go down the line. With atlas, so with occiput, I would say absolutely it's possible for multiples with occiput because all those foramen are being shifted. With atlas, yes, it is. I would think if you've got a torticollis, say, and it's a spasmodic, so it's affecting cranial nerve 11, there's still a really good chance you're affecting cranial nerve 10. And it's possible you're even affecting cranial nerve 7. Because you could end up with somebody who had that really bad and they may even have Bell's palsy with it. So one of the weirdest ones I ever had. So the loss of smell and taste with COVID, I think is just because the virus finds its way to the brain. And then once it's in the brain, it can start traveling down other nerves. Why that particular virus has an affinity for cranial nerve 1, I have no idea, but it does. So it does its thing. What was I thinking of? Oh, well, I forget now. So a weird one I saw. I had a patient, and this was actually early on in practice. I probably didn't practice maybe a year. And I had a patient who had shingles, and the dermatome was C1. So it was his atlas causing his shingles. It went behind his ear. The rash went behind his ear, came down his jaw, came down this way, like towards the corner of his mouth. He developed Bell's palsy with it. Had when he smiles, has these really deep dimples. Totally lost the dimple on one side. So he came to me because the medical doctors told him that the shingles would go away, but the Bell's palsy would probably never go away, and he'd have that for life. So he came to me, and I was like, well, we'll just do what we can do and see what happens. So I painted it, scoped it, everything. Yeah, C1. So we adjust C1. It took, if I remember right, it took 3 adjustments of C1 and the shingles were completely gone. It took, I think, 5 more adjustments to C1. And these were in rapid succession. So I probably was seeing them 3 times a week because it was something that I knew that if we just did a bunch, we could get them better. So I think we're doing 3 times a week. So 3 visits actually equated to about 1 week and the shingles was gone. And then about 5 adjustments and his Bell's palsy was completely gone and his dimple came back. And I don't see him very often, but I see him once in a while still. I've lived here long enough. I know people. So I knew him before he was a patient. I see him once in a while. He's got his dimples. You would never know he had any problem with any of that. So that was a case where cranial nerve or spinal nerve 1 coming off of atlas, somehow that got tangled up or it got in there, and because of close proximity, it affected cranial nerve 7. and he ended up with Bell's palsy with it. But fixing Atlas fixed both of them, both problems. So, anybody have any questions? Any other questions? Oops, I did. Let's see. Yeah, so I think if you had a hypermobility of C2, you would be thinking that most likely this person probably has an upper cervical problem. And then you scope and you get nothing. And you palpate and you find nothing. And you're like, well, what in the world? What do I do now? And so that's why it's helpful to know that if it's probably is being caused by the hypermobility, so you're not on the wrong track, you just got to figure out what's causing that hypermobility, fix that, and you'll fix the other problem. But that's what will happen. Because it's not common, but I would say most of the time that I suspect something like that, through scoping and palpation, it actually is going to lead me to Atlas or occiput. But every once in a while, you get the symptoms, and you go to check it, and you're like, I find nothing. Now what do I do? No, not necessarily. I think once it's damaged, once you've lost taste and smell, but you know what? I am hearing reports from people that people are gaining it back at different rates. So I've heard of people who it took them a year to get it back. In my case, I got it back. I got it back before I really even felt all that much better. I thought I had no taste and smell, but I was feeling good enough. I decided to go outside, and while I was out there, I thought, I'm just going to clean up the dog poop while I'm out here. And then I was throwing it away, and I was like, whoa, I got my smell back. So it was pleasant, unpleasant surprise. So mine came back pretty quick. With the heart problems that go with that, you would expect things like palpitations, arrhythmias. It can affect blood pressures. Typically when either systolic or diastolic by itself is out of whack. So one's messed up. So I don't know if it's true or not, but classically they always said that Gonstead said that systolic is a subluxation. If your systolic is messed up, that's a subluxation problem. And if your diastolic is messed up, that's a diet problem, is what he always said. But I think you can affect both in different ways. But you might get some of that. You also could get a change in pulse, or it's either racing or it's slow. But at the same time, those are common problems people have anyway. I think what I look for with that is some symptom that they can tell me came on recently, and they'll tell you, I didn't have this before, but now I'm having this. So for me, it's more the fact that now they're having this more than even what it is. Just some change in heart function, great. Let's make a change and see if we can undo the change in heart function. Yeah, I think over the long haul, it will start to cause problems with that. I think even more so if they've torn one of those important ligaments that holds the disc in place. If the disc of the TMJ is getting a lot of translation, a lot of sliding, that's going to mess it up even sooner. Whereas our normal discs, they like to move and they get in trouble when they're frozen. That disc likes to just kind of pivot. And that's really all it does, is this little pivoting dance. And when it starts sliding and you're getting a lot of translation, that beats it up and wears it out a little bit faster. And also, it's a timing issue. That disc, if you watch that yoink video, you'll see that in normal function, it just kind of glides as it should. What it'll start doing is some of the dysfunctional ones, the jaw's moving and the disc just sits there and it builds tension, 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 and then it jumps. And it builds tension and it jumps. That's where the clicking, popping comes from, is that it's just sitting there building this tension and then popping over the top. So that's real dysfunctional movement. So one of the things I got from that yoink video is that there's a lot of ways that it can go wrong. There's not one way that it goes wrong. And after watching that, I thought, I actually found that video because I went to a dental seminar with my wife, and the guy played that video, and I was like, I must have this video. I got to find it. And once I saw that, I thought, man, we've been oversimplifying the TMJ big time. There's way more to it, and there's way more that can go wrong. So I think the TMJ is a lot more complicated than what we generally do with it, but be that as it may. I don't. Yes, a TMJ can affect the cranial nerves, but it's typically going to affect the cranial nerve from the TMJ down to the end. It doesn't feed backwards the other direction. However, you can have Atlas do that. So I had a patient for a while. The last orthodontist who was here, he and I referred back to all the time, and he sent me a patient who had a TMJ problem, and the patient came in and said, Dr. Schwartz said he can't help me. I was like, well, that's unusual. Usually Dr. Schwartz sees it as like we both do a little bit, he'll make a splint. And I thought, well, that's odd. He said, he really said he couldn't help you. He said, yeah, he looked at all my teeth and took x-rays to fill it. He said he couldn't help me. So then he sent me to see you. I thought, well, that's odd. So I looked at he had it clicking and he jumped down on the side, and I evaluated his TMJ, and I was like, all right, there's definitely something going on here. And I thought, well, okay. I said, indulge me for a second. And I grabbed my scope and I thought, I just want to check his neck really fast. So I checked his neck. I thought, because I want to make sure the neck foundation is good before I set the TMJ. Check his neck, palpate everything. He's got an Atlas problem on the left. Okay, so I adjust his Atlas. I adjust his Atlas, and I'm coming around to start working on his TMJ, and he's opening and closing, and he goes, my TMJ problem's gone. I was like, seriously? So I came over and I palpated it, and he's right. The clicking was gone, the popping was gone, the motion was perfectly fine. So Atlas can cause TMJ. TMJ, I don't know if it really causes Atlas problems, but you can see them go together. And but TMJ tends to, if your TMJ is the problem, you're going to end up with nerve problems from there to the tip of the chin. It's going to come down this way. It's not usually going to be anything higher than that or back to the neck.
Dr. Fowler, have you ever seen the ones they teach in school where they thrust down the TMJ?
Oh, whoops. I need to talk to him, but I can't hear you for some reason.
Can you hear me now? Can you hear me, Dr. Fowler? I could type it.
I can't hear you. Oh, yeah. Well, watch that yoink video and then tell me that's a good idea. It's like the worst ever idea. In fact, I would say, looking at stuff that dentists produce, most dentists understand that it needs to come up, like it needs to be up there and whole. Actually, what I would say you're in the biggest risk of is that thrust down. While it might make a nice cavitation, that cavitation you hear might very well be the rupturing of one of those ligaments that needs to hold it up. I think that is like the dumbest way to go, because there are ligaments in there that hold it to hold your jaw back and to hold you up. And you start thrusting down on those, they only have so much give. And eventually they're going to rupture. And I think if they ruptured, it probably would sound a lot like a cavitation. Okay, when the jaw, locks open? That's interesting. The locked jaws are usually the PS, not the AI. I haven't seen a lot of those, but I've seen a couple. I had a girl come in years and years and years ago. She came in and she was slightly open, like maybe this far, and she couldn't move her jaw. And then she told me that she could only eat what she could suck through a straw. And she'd been hurting with it for like a day or two. I was like, why it took you so long? So what I ended up doing is I put on a glove, stuck my hand in her mouth, put my thumb on her back molars, and then used my other hand for support. And I tractioned it down and out, and then gave it a quick tug. And it took like 2 or 3 tries. It was really stuck. And then when it finally came, it went pop, and instantly she could move her mouth and she was fine. And it's, again, that's something I still know today. She's never had trouble with it since then. But I kind of like this. God. And pulled it down. So all the weight of my thumb was like this on the bottom teeth to pull it down. You can theoretically do a PS from up here and set it down, but hers was so stuck. I set up like that, and there was just no way. It was way too stuck, and I had no leverage. So I thought, okay, I need a position with more mechanical advantage. So I stuck my thumb in there and pulled it down. The hard part was I was like, please don't bite me, because it might hurt, and I don't want you to bite me. And so my thumb is along all of her molars, and if she bit it down, she probably would have crushed my thumb. But took a chance. Okay, so on the jaw, when they open, if one side is stuck, the other side is going to keep going. So the jaw is going to deviate towards the stuck side. You can also have them get pretty complicated. I just had one like this like a week ago, where it was both sides at different points. So the jaw's jutting back and forth and back and forth. So when that's the case, you want to fix the last one first, and then just do one jaw at a time. Yeah. So, yeah. So, I think you can. That's actually something that I talked with Kayla Franzlubers about that after we talked for an hour when we were not recording. And we were talking a little bit about cranial stuff because the pediatric designation that I have is very similar to what she has. It's just time went by and they changed it, but the actual training is very similar. And so we both recognized that in the course of that training, we were presented with cranial work. And so I see the value in it. And I've experimented with it a little bit. I don't do a lot of it, but I have experimented with it some, and I do see the value for some of that stuff with it. But a couple years ago, I presented at the extravaganza, and it was funny because the docs who were in the room all said that was awesome. And the students complained that I was teaching stuff that wasn't Gonstead. And I didn't even do anything except that somebody asked me if I did anything besides Gonstead. And I said, well, sometimes I'll do some cranial stuff. That was all I said. And for that, it was like, he's not doing Gonstead. Or whatever. So the truth is, and it had to do with frenectomies, because a lot of times when you get a kid who's got a tongue tie or lip tie, they're not symmetrical. So it pulls with like this weird angle direction. And you can see how their head is under this torsion and shifting. And so it makes sense once you've released that. Why not see if you can kind of shift some of that back? Like that makes sense. It's not like I'm doing it on adults. These are kids with open sutures and whatnot. So I think that's a little bit different. So in that population, for sure, that's why we were talking about it, is in the pediatric population. I think you see a lot of stuff where some cranial work can be very beneficial for them and probably would have a lasting effect, because if you can fix it while they're young and the joints are open, you can fix them for life. And now they're not going to have potential cranial nerve problems that might come up later because they're all distorted and have a weird shaped head or something. Oh, you're welcome. You're welcome. Glad to do it. You're welcome.
Can you hear me at all, Dr. Fowler, or no, by chance? But,
You're welcome.
Yeah, thank you for coming. And guys, we have the chapter challenge going on too. And if you haven't yet, you want to check out that donation for the clinic. We'd appreciate everyone if you can do anything you guys can. But thank you, Dr. Fowler, when he can see this video and hear this. And thank you guys for coming on
I
tonight.
know
We
why I can't
appreciate it.
hear. There. I think that's why I can't hear you.
Is it working now? Can you
Nope,
hear
I
me
still
now?
can't hear you. That's wrong.
Okay. Well, I was- Thank you.
You guys are all welcome. Thank you for coming in here.
Thank you.